how do I get my doctor to believe that I have a protracted benzodiazepine withdrawal injury and not something else? This is a question that I get all the time. And unfortunately, many doctors have never even heard about the condition. And even those who have, they don't really know how to diagnose it or even help someone recover or support someone during their recovery. And so this is a big problem, especially if you're going to be relying on them to support you. So today, I'm going to create a video that you can personally show to your doctor that will give them a very quick introduction to the condition so they can better look after you. Dear colleague, thank you for taking the time to learn about an important and serious adverse reaction that may be affecting your patient. I'm Dr. Josef Witt-Doerring. I'm a board-certified psychiatrist, former FDA medical officer, who specializes in treating psychiatric adverse drug reactions. The condition that we're talking about today is called protracted benzodiazepine withdrawal, and you may have never heard of it since it was only added to the FDA's drug labels in 2020, and it came out without a corresponding Dear Doctor letter. And in this quick video, I'm going to quickly cover the essentials that you need to know to support your patient. First, what is protracted benzodiazepine withdrawal, and why does it occur? Protracted withdrawal is an uncommon adverse reaction that typically occurs when stopping a benzodiazepine medication. And although the use of the term withdrawal in the name suggests that it is a time-limited withdrawal problem, protracted withdrawal is best understood as a nervous system injury that occurs within 2 to 6 months of abruptly stopping a benzodiazepine medication. Although there are cases that do emerge gradually over time, the majority occur right after someone has stopped the medication cold turkey. After someone develops protracted benzodiazepine withdrawal, it can last for many months to several years. So why does this occur? It's not really known why it occurs, but because it tends to appear following abrupt discontinuation of a benzo, there appears to be something about severe withdrawal states that might be neurotoxic in susceptible individuals. It's currently unknown why only a small proportion of people develop this problem following acute benzodiazepine withdrawal. So what are the common symptoms of protracted benzodiazepine withdrawal? This condition can manifest with lots of symptoms, but in general, it causes a global neuropathy that manifests with neurological and psychiatric symptoms. The typical symptoms include severe anxiety and insomnia. These are probably the most common. And then there's also symptoms such as tinnitus, visual sensitivity, paresthesias manifesting in possible symptoms like burning, numbness, or tingling in the hands and feet, autonomic dysfunction, which causes things like racing heart rate at rest, swollen hands and feet, changes in sweating, neuromuscular dysfunction that can result in feelings of internal tremors and muscle tightness or weakness. There's a lot of severe gastrointestinal problems similar to IBS, with problems such as constipation, persistent feelings of GI fullness, and discomfort and diarrhea. So what is the treatment of this condition? To date, there is no pharmacological treatments that improve this condition. The only factor that I'm aware of that improves it consistently is time. Simply put, the nervous system needs time for neuroplasticity to gradually allow for healing and recovery. In my experience working with these patients, I've used lots of medications that are typically used for neuropathy, things like gabapentin, Lyrica, tricyclic antidepressants, duloxetine. And although it seems like they might be useful, I've almost never had any luck using these medications to treat these symptoms. They all either make no difference or they've made some people worse. I've also tried using drugs like lithium, Depakote, verapamil, and other meds that are commonly used for conditions like migraines without effect. Because of this, I typically recommend to my patients that they focus on non-drug therapies to help them cope with symptoms. So what is the prognosis of this condition? Well, this condition can be incredibly painful and uncomfortable, but it is not progressive and it actually has a good prognosis if the patient can be supported well during recovery. So although there are no clinical studies on this population, I can provide some rough estimates on the time course of recovery from having supported hundreds of these patients in my private practice. Roughly, it feels like 40% of them recover in less than 18 months, another 40% within 5 years, and about 20% appear to have problems lasting longer than 5 years. All patients appear to gradually improve over time, and even those with long-lasting symptoms typically reach points within a few years into their recovery where they're able to return to partial functioning. So if you are struggling to help your patient now, please rest assured that this is likely the worst that they're going to be, and if you can support them through an additional 6 months, it's quite possible that their symptoms will step down in severity. What are some of the common pitfalls that you should avoid when treating this condition? The first thing I want to mention is that you should be very cautious about using additional daily psychiatric or neurologic medications. For reasons unknown, many patients appear to be at higher risk for adverse reactions to these CNS medications. This could be due to the widespread neuronal damage that makes the neurons respond less predictably to the medications. But it is also likely that many of the patients are actually primed to also have negative responses to new medications. This is expected given the trauma of having experienced a severe side effect already to a medication and the impact that that's had on their lives. So if you decide to try an additional medication, I would recommend that you introduce it at a quarter of the usual starting therapeutic dose just to test response before going any higher. Also, please, if possible, avoid using fluoroquinolone antibiotics or other medications that have a known side effect profile that could cause further neurotoxicity. This could include avoiding medications like metronidazole or Flagyl, or even medications like montelukast or Singulair. The best way to know if a medication is safe is to review Section 5 of the US drug labels, warnings and precautions, and to make a note of any neurotoxic side effects that might be listed there. This information is readily available on the NIH-hosted website's Daily Meds. So what do I do if my patient needs surgery? Can they tolerate anesthetics? Although many patients might be worried about one-off exposure to anesthetics, from my experience, most patients have tolerated midazolam, ketamine, propofol, and other anesthetics for urgent screenings such as things like colonoscopies or emergency surgeries. Next, what should you do if your patient is wanting to taper medications while having this protracted withdrawal injury? Given that your patient has already demonstrated that they are susceptible to withdrawal-related injuries, I would recommend slowly tapering their medication in a way that avoids additional withdrawal symptoms. This may involve doing a taper over several months or sometimes even several years. What are the best ways to support your patient during recovery? Because the primary treatment for this condition is time, all efforts should be focused on helping them live as normally as possible during their recovery. There is a wide range of places that your patient may be during their recovery, ranging from completely bedbound due to severe anxiety or neuropathy to being mostly functional. Work with them on an individual basis to find small things that they can do to feel engaged in life. Engaging in life is the best way to pass the time while healing. Normal factors that support good mental health should be emphasized, such as being around people they love and trust so they don't become isolated, walking outdoors in nice green spaces if possible, being engaged in work or family life in creative ways, and also making sure that they're involved in their work or their family life in creative ways that don't overwhelm them at their current level of disability. Try to ensure that they always have one thing to look forward to each week to stave off the depression that can be very common when suffering from this condition. Most importantly, you must continue to remind patients that the vast, overwhelming majority of people recover eventually and that they should not give up hope. Some patients may also become suicidal due to the pain and the abrupt change in their life. Many of them have been looking forward to retirement or having children or raising children, only to have that dream lost for now. They will likely be depressed, and there's going to be a very natural grieving process that's going to occur during the start of this. Reassure them that you will be there with them to help them each step of the way until they get to the other side of this. Because suicidal thoughts can be common during this condition, involve their family members in a discussion where you can ensure that they don't have access to lethal means such as firearms or large pill bottles of toxic substances. Also, it may be important to ensure patients have support financially. Encourage them to look into their options for short and long-term disability. And finally, this condition is very challenging for the caregivers. Make sure that you have open discussions with the patient and their caregiver about what can be done to ensure that the caregiver doesn't become completely overwhelmed and burnt out while supporting their loved one. So next, how do I prevent protracted withdrawal injury from occurring with my other patients? Because this condition appears to emerge following severe withdrawal symptoms, the best way to prevent protracted withdrawal injury is to taper your patients in a way that avoids substantial withdrawal symptoms. Most long-term users will tolerate a 5 to 10% reduction every 30 days without substantial withdrawal symptoms. However, the speed should always be modified and slowed down if unpleasant withdrawal symptoms emerge. An excellent example of tapering plans can be found in the Maudsley Deprescribing Guidelines. So what are some additional resources where you could learn about this condition? In the description below this video, I've included 3 important links. So the first one is to the FDA's labeling for Xanax, which describes the protracted withdrawal injury in Section 9. I've also included links to 2 articles on protracted withdrawal injury, which describe the condition in further detail. So I hope this video has provided you with valuable information that will aid in the care and support of your patient during their recovery from protracted withdrawal injury. Thank you for dedicating time to learn about this significant condition that may be impacting your patient.